is Jeff Roscoe. I'm the Associate Director for the Mailman Center for Child Development, and this is part of our Mailman Center Grand Rounds. So I think all of you know that every month we have a Grand Round speaker, and typically in the fall, in September and October, it's a speaker that appeals to the entire Department of Pediatrics and even beyond that. And then in the spring, we usually have more focused kinds of Grand Rounds that are particularly for child development and child behavior issues. We are so lucky today to have an out-of-town special guest speaker about whom you'll hear a lot in a few minutes. We decided this was worth opening up to the entire Department of Pediatrics. So thank you all for being here, and I'll introduce Asha Pillai, who's going to tell you more about our speaker today.
Good noon to everyone. I'm going to keep this very brief, mainly to give Shalini maximum time to interact with everyone. So I have the privilege of introducing Dr. Shalini Shenoy. She is Division Chief of Transplantation, Stem Cell Transplantation in Pediatrics at Washington University in St. Louis. She has a long history there of leadership in clinical care, research, and teaching. And she has a national reputation and actually international reputation in pediatric stem cell transplantation and immunotherapy. She is well recognized as a leader in curative transplantation for non-malignant disorders and particularly for hemoglobinopathies. One of the most important things that she's moved forward in the field is the use of alternative donor transplantation to try to help what we've talked about in the past in other presentations that you've heard here, to enhance the curative options for children and young adults with sickle disorders and hemoglobinopathies. And because of her long history in this area, she's been called on many national and international panels. She has served in leadership roles related to the National Heart, Lung, and Blood Institute, the American Society for Hematology, among others, and as well as the American Society for Transplant and Cellular Therapy. So those are the roles in which we've had the privilege of interacting with her nationally and internationally. Because of her past history, she also has some unique data on cognitive outcomes in transplant, early curative transplant for these disorders, which I think is going to be also particularly interesting and apropos to the Mailman Center. Due to her schedule, we were able to get her to make it down here in the winter months on a Friday, so we're very privileged to have her. Thank you, Jean.
Well, thank you for that introduction. I barely recognized myself when you introduced me, but thank you for having me today. I have met several of you since yesterday, and it's lovely to be here. It's also lovely to be here since I left 28-degree weather and a snowstorm to come into sunny Miami. It was raining, and that was just fine compared to the sleet and ice that we had over there. So it's a pleasure to be here in this beautiful city. I hope to talk to you about curative options for sickle cell disease, which is something, as you know, is a topic of national importance lately. Is that better? And I think a lot of people, everybody is racing for the cure, and rightly so, because over the last sort of 20 years, the natural history of the disease has become more apparent with better data collection and better follow-up. And we do know some of the challenges that we face with the disease. And what I want to show you is some of the challenges that we face with the race for the cure as well. So the balance is we need to take steps forward, but we need to take them carefully so that we do the best we can for our patients going forward. We learn from past lessons and then move on. But what I hope to show you is that we have taken several steps forward from the first sickle cell transplant that was done in 1984. We're working towards improvement. And I also hope to show you that, of course, there are challenges and there are victories, but hopefully the balance is tilting more towards victory than the challenges that we face. Though I don't think we're not over the hump. We're just trying to get there with improvement one at a time. So the learning objectives that I put together for this was we were going to talk about that, we will talk about the curative options, we were going to talk about the benefits and the pitfalls as they stand right now, and the long-term follow-up strategies that are absolutely necessary for us to know what we're doing with each of these interventions. So just briefly to put sickle cell disease in perspective for those of you that don't deal with this disease all the time, there are about 100,000 people in the United States with the disorder, 1 in every 365 African American births, and 1 in every 16,000 Hispanic American births are born with sickle cell disease. 1 in 13 African American babies are born with the sickle cell trait. And at the last look, long-term follow-up was a huge problem in patients that were recognized to have the disease, and over 30% of these people didn't have a long-term plan for follow-up. I think we are particularly privileged in pediatrics because the care in peds is much better than it is as these patients grow older. And sickle cell disease is a global problem, as you all know. More than 300,000 births annually with sickle cell disease, 10 to 40% of the population in African countries. So the disease, you all know, has these hallmarks of complications that change with age and that actually worsen with age. So the first 10 years of life may be the best, and then as time goes on, the damage catches up in most people, though at different rates. So somebody that has very severe disease could be very sick in their second decade of life, whereas someone who doesn't have these major complications could go as long as 30 or 40 years before manifesting major problems of the disease. However, the patients that we see in our clinics, especially in our older age group and our transition clinics, are going to be those that have the more severe manifestations of the disorder, because obviously you're going to come to the doctor much more frequently, depending on the number of complications that you have. Otherwise, some of these patients we probably don't even see out there. And unless you have very careful registries tracking everybody with the diagnosis, it's very hard to come to a understanding of how vast the difference in presentation is. Now, all of you know, just briefly, that sickle cell disease, it's not just the sickle cells that are the problem, but it is the breakdown of the cells and the breakdown products, the increased adhesion molecules that are upregulated, the platelets, the endothelial damage, they all work together to cause the problem. So, if you started out with no endothelial damage and you had a child that was cured, that might be different from a patient that also had an extensive amount of damage, and the reversibility of that damage then comes into question when you provide that option later in life. So something to think about. So I don't think that cure in a 5-year-old and cure in a 35-year-old could be the same thing. So we're not going to be able to look at it through that same lens and say, this is my parameter for the cure and this is what I'm going for. It's going to be very different depending on when you have an intervention and how severe that disease is before that intervention comes into place. Just briefly, I want to touch on some of the data that we know for patients with the disorder. This one here is the lung, and the FEV1 in a group of patients followed over a period of time has a gradual decline, as you can see here. So these have to be done. So the patient is not necessarily symptomatic until they get to a pretty low FEV1. And this, as you can see, is the age below in years, and so you're talking about 3 to 4 decades before the symptom manifestation catches on. This, on the other hand, is a pediatric population that was looked at for physical functioning and for psychosocial health. Anytime you start with a normal, say, physical function, and then you have these patients going through presentations for vaso-occlusive crises, vaso-occlusive episodes, and you can see how there's a dip in both the physical and the psychosocial function. Not hard for us to imagine, because whenever you're sick, you don't feel that good. Your psychosocial health isn't going to be good. But the problem here is that this happens repeatedly in your patient, whereas for someone that's sick occasionally, you have something to look forward to. I'm going to get over this and it ain't going to happen again. But not true for a patient with sickle cell disease, so really hard. So this kind of data wasn't captured before. We only knew patients who had the overt stroke and had, say, neurologic manifestations that were permanent. But these are quality of life issues that I think we also need to think about when we think about patients with this disorder. And people, physicians, nurses, support staff that treat patients with sickle cell disease, I'm not telling you anything new, but I think this is something that all of us need to think about. Now, one of my colleagues, Alison King, has done an extensive amount of work on their performance, their neurocognition and IQ, and I know there's a lot of expertise here with Dr. Armstrong's group on neurocognitive changes with sickle cell disease. So Alison looked at groups of people and sort of divided them out by education, by socioeconomic status, and with or without the disease, and showed that the disease itself, irrespective of these other variables, there was a slow drop of IQ with age that we didn't know in the past. We have only recognized this since we have formal ways of checking these patients. And if you have a grant or funding that allows you to do this, this is doable. If you just write to your insurance company and say, I want to test my patient's IQ, they're going to look at you and go, you must be crazy, we're not paying for it. So that is the problem. So I think now with this collection of data, we know what the changes are. This here is another indication of what it does to the IQ. So these are patients with silent cerebral infarcts, where if you didn't have an infarct, your IQ is clearly higher than if you did have an infarct. And this doesn't even take into consideration people that develop infarcts that increase with time. So if you did a sequential analysis of this, you would probably see that declining. And some of this decline is potentially because of the neurologic changes that silently happen in patients. So mortality rates are a lot more objective, right? What is their survival? So you definitely have supportive care measures these days that have helped children out a whole lot, and mortality has come down, especially in developed countries. So we're talking about 94% of patients with sickle cell disease, 99% in the UK. That survive definitely through their pediatric and their first and second decades. The trouble is in the adult population, it's been a little harder, and their lifespan is still in the 4th or the 5th decade. The median lifespan is still there, mostly because, like I said, the complications catch up later with all the supportive care that you offer them initially. It's really hard to continue supportive care forever. Even if it's you and I, think about if someone told you you have to take vitamin D every day because it's good for your bones, how many of us manage to do this lifelong? It's really hard to go through the supportive care that you're going to need to stay in good shape for life. And the mortality is multiple. It's cardiovascular for the most part. It's neurologic, it's multiple renal disease, hypertension, and there are some markers, the TR jet velocity, the BNP, this 6-minute walk test, they've all shown, the hemoglobin F levels, they've all shown to be indicators of early mortality. If you track it and they become abnormal, then your patient probably is going to end up in more trouble. There was also some discussion in the past about white cell counts and differential counts and leukocytosis that didn't quite pan out in the long run. So markers are few, but there are some that can be tracked for sure. And we, the management is supportive, we all do this, is symptomatic, is preventative, and it's abortive. So you try to stop your complications from happening when they show up. These are when your patients show up in the emergency room. You go with supportive care for longer term, symptomatic treatment at home, like your home pain plans and so on. And then prevention, you tell them stay hydrated, avoid really harsh. All this is easier said than done, because when you have a patient that needs employment, when you have patients that need to move on with their life, a whole lot of restrictions aren't going to be easy to manage for a particular patient that is trying to just get their life going and get their life in order. So difficult. Now, this is a list of drugs. We're talking about sickle cell disease over, 3 decades, and we have 4 drugs right now that are useful in the disease, at least in part. So you can see how difficult it has been. And of course, there's the chronic transfusion therapy in addition to this that has definitely helped people in the long run, but very few medications and very sparse benefit that says that we've got to do more, or at least try to do more to the best extent that we can. So some of the facts that we know of curative options is that successful sickle cell, successful transplant, especially from MACID donors, if you can bring their hemoglobin S levels to less than 50%, it does end the sickling process and decreases stress on your endothelial cells and helps them revert back to normal with time. And I'll show you some data on that. So MACID donors are obviously the best donors, not just for sickle cell, but any disorder. A MACID transplant is probably the most efficient and have the best outcomes. Autologous transplants with gene manipulation are definitely very attractive because you're not going to land them on immune suppression, and you don't have an allogeneic response to deal with. So if you can give them the cure without an allogeneic response, that definitely gives them a leg up for toxicities. But the pros and cons of a cure should confirm that the pathophysiology control is lifelong. And here is where I think we're lacking, because if you take any transplant publication, or if you take any publication that is looking at a curative intent, we're just looking at sickled cells in the first year or the first 2 years after we transplant them. We don't know 15 years down the road, did we change their disease? Did we give them longevity of life? Did they go back to a normal lifestyle from where they were before the transplant? And the reason for that is not because we don't want to do it, but because the funding for that wasn't a priority for anybody, because everybody wanted the short-term, immediate outcome analysis and not the long-term. Now that is slowly changing, and support for registries, support for longer-term follow-up is becoming much more common. And I think we'll have that information with time as we go along. But I want to make it a point here that when you are thinking of an intervention for anything, this doesn't have to be sickle cell, that long-term follow-up in terms of what you've left your patient with is really important, both for toxicity as well as for the efficacy of what you've been doing. And the variability, which I alluded to earlier, helps tease out to some extent how you're going to intervene in your patient. So if you have someone with really severe disease, that's the patient who's probably going to be eligible for your intervention trials first. And then if you prove that that's reasonable in that population, then you bring it to your population that is not as affected, because your first rule is do no harm. And so got to keep that in mind as we consider these patients. So transplant, I would say, is curative if you define it as a hemoglobin S level that is acceptable. So you can take a unaffected donor, you can take a trait donor, anybody that can bring your hemoglobin S to less than 50%. So your 5-year overall survival, 5-year event-free survival after massive donor transplant is in the mid-90s at this point. And so I think we are at the point where we can say this definitely, at least short-term, is of benefit to your patient. And we, I think, are a lot more comfortable now saying a massive donor transplant is something that is a potential, reasonable, valid consideration for your patient. Now, 5-year overall survival differs depending on when you took them to transplant, because if they're older, you have a, remember you're bringing your patient with more toxicity, more organ dysfunction, and whether you can bring them back to normal is not, we still have to track that. And how much of their manifestations are reversible depends on what it is you're referring to. For example, I always tell my patients, avascular necrosis, for example, you are not going to be able to reverse that with transplant. Though their acute pain crises come down, if you have a joint that's involved, you're going to need joint replacement, but you're hoping that future joints don't get involved, they don't get affected, so you're helping them in that way, but you're not going to reverse the process. If they already had a stroke and they had a ischemic stroke that left them with neurologic deficit, you're not going to change that, but you do know that a patient that had a stroke or a TIA or a CNS manifestation runs the risk of developing it over and over again despite chronic transfusion therapy, and there's your justification for saying I should try to do something in this group of patients. So words of caution there. So if you look at outcomes by donor source, the top blue line, I don't know if you can see this, okay, not. Well, the top blue line is the massive donor outcome, and what you're hoping and what your study should do is try to bring all these other donor outcomes up to where you are with your massive donor. That is the goal. But if you looked at this and said, I'm not going to subject my patient to these others because their outcomes are not good, I don't think you're helping them any, because medicine is like this. You start somewhere and you improve upon what you did before. And what I hope to show you is that that improvement is something that we ought to be striving for, because otherwise we would never have transplanted a leukemia, right? The first leukemia transplants, 80% of patients died. Now, less than 10% die. So unless you have studies, you can't do this, but that also, the corollary is that you gotta do it as part of a data collecting study so you can improve on what you know from before. So that's my message. But really our goal is to try to get to the best that we can with these interventions. And if you look at the data, you know where you've got to improve. So you've got an age-related difference that I talked about. You've got a regimen-related difference. You've got to make your regimens as safe as possible. And you've got a donor difference. The donor has to, if a donor that is available to you, you need to bring that outcome to match what a massive donor might do. Now, this is a look from, I would say, from the 100th floor down to the ground, because now you're putting everybody who got a particular kind of transplant together. There are variations between them. So they're not, this doesn't hone in on any particular kind of transplant. It just says, here is where your options for improvement are. Now that was acute graft versus host disease, and this is chronic graft versus host disease, where there is a definite difference in age, the risk of chronic GVHD, but it's also true that your alternate donors are not as good as your MAT-CIP donors, and that's where the work is that needs to be done. And this is something that we put together to look at the patients between a group of our institutions, to look at the difference between MAT-CIP and alternate donors in terms of chronic GVHD. And what we see is that in your MAT-CIP donors, your GVHD risk comes down to 0 after that first year. You do have dropping GVHD rates and it comes down to 0. So if I told you that 20% of patients got GVHD, they probably got it in that first 3 to 6 months, and then they got back down. They got to mild and they got to 0. So it's something to keep in mind that this is a changing event with time. Whereas if you look at the chronic GVHD rates, and I talk to my patients about this, it does come down with time, but look at the time. It's out at 2 years, and then if you take it out beyond that time, hopefully it'll come down. But that also means that they have to listen to you and follow the rules and be compliant for that much longer than if they were a MAT-CIP donor transplant. And unless they understand this, you're not going to have a patient that is compliant. And if they don't believe that they can do this, they should never come to transplant, because they are not going to be the right population for you to transplant. So a whole lot of nuances. It's not just a straight outcome, but it's also who are you dealing with, what age are you dealing with, and how equipped are they to work with you in terms of their needs is very important. Graft failure, I won't go into details on the numbers, but I wanted to show you that these are your main outcomes: acute GVHD, chronic GVHD, graft failure. What are the differences between alternate donors and your MAT-CIP donor? And that then, of course, translates into event-free survival, where alternate donors are still very different from the MAT-CIP donors, and so that's where your work is. So take-home message is that if you are over 13 years of age, you're at a higher risk for starting complications, you're at a higher risk for post-transplant complications. Graft rejection and GVHD rates increase with age. Cord blood transplants have a higher risk of graft rejection, so you've got to try to get your conditioning where they can get the graft in. And acute and chronic GVHD risks are more, like I said, with increased age. We also know that peripheral blood transplants, whole peripheral blood, is not as good as bone marrow or cord blood because it does have increased risk of GVHD. So some of those things are for the transplanter to focus on, saying, my study is going to do this, this, and this, for this, this, and this that is a problem with previous transplant trials. So we and others have looked at conditioning regimens that are backed off in intensity for purposes of toxicity. So they are reduced intensity or non-myeloablative. So I've got 1, 2, 3 here to give you a sort of overview of what these reduced intensity and non-myeloablative regimens look like. And each of them has their own nuances. Now, if you take number 2, where you have alemtuzumab and TBI with sirolimus as a long-term GVHD prevention mechanism, you could land up on immune suppression for a very long time, because if you pull immune suppression, they may lose their graft because it's so low intensity. It may be okay for somebody who's 35 to say, you got to take this drug for a long time, but I don't know if you can do that in a 5-year-old, if that is indeed the case for a 5-year-old. So there is a trial now looking at this in pediatrics to see if it pans out that they need long-term immunosuppression, or can they come off of it with a stable graft. Again, a question, has to be done as a trial and is being done as a trial. We did a alemtuzumab, fludarabine, and melphalan approach to a reduced intensity conditioning, and the MAT-CIP donors tolerated well. We found that the incidence of PRES and the incidence of GVHD was higher if you did it with an unrelated or a mismatched unrelated donor transplant. And then you have the Hopkins approach at the bottom with the post-transplant cyclophosphamide that has been exciting in terms of controlling chronic GVHD, though acute GVHD rates are still there. And so people have now made changes, and that's what we're trying, and that's what others are trying, where we have taken out prednisone because of the PRES risk out of this whole equation and gone on to GVHD prophylaxis. That is different. The patients that have received alemtuzumab and TBI, for risks of graft rejection, they've increased the amount of TBI that they've given. As have the haplodonor transplants, they're looking at the addition of both Thiotepa and TBI to try to reduce their risk of graft rejection. So these adjustments are made based on past data to try to improve on outcomes. What we have done is used abatacept in our GVHD prophylaxis after giving up on the steroid. Because it is a co-stimulatory molecule blocker, it has been shown to be very beneficial in malignant disorders. We took Leslie Keene's data. She's done a lot of work on this, and we're working with her in terms of using it in our patients with sickle cell disease long term. The same thing is true for the post-transplant cyclophosphamide. You got to have a patient who doesn't have major renal problems or is at risk for hemorrhagic cystitis. So everything comes with its ups and downs. You got to be wary of that. People that have switched to sirolimus have done it to increase the regulatory T cells to try to decrease the graft versus host disease risk, as opposed to a calcineurin inhibitor that might give them hypertension and renal toxicity. So this is just our experience with abatacept that was presented at ASH recently. So this was a phase 1 going on to a phase 2 trial, and our phase 1 is completed with an overall survival that's at 100% and event-free survival of 90-something, because the one patient that lost their graft in this had active CMV disease that we then treated, and the patient needed long-term CMV prophylaxis. So I think that this is what I mean by improvement. This is by no means the rule at this point. This is a study and needs to be looked at in the long term in terms of how it is going to do, but it's actually enrolling matched unrelated donors as well as mismatched unrelated donors, because those are the ones that are at high risk for their graft versus host disease. Now, just a brief word on additional considerations. Infection risks with immune suppression are always a big problem, and depending on the area in which you are, you probably have native infections that you worry about based on your weather and the change in your weather cycle and so on. For us, it's influenza, and it's the viruses that come in the winter that we are very wary of. We tend not to take our non-malignant disorders to transplant in the winter for fear of RSV and so on. We try to do it so that their immune system is up and running by the time winter comes. We maintain platelet counts, and of course you have the prophylaxis that you have to use based on where you are and what infection you need to worry about. Maintain platelet counts over 50,000 is very important. As transplanters, we know this. If you have a patient at risk for a bleed, like a CNS bleed, as in your sickle cell disease patient with endothelial damage, it's a problem. Gotta keep PRES and hypertension under control. Gotta check on alloimmunization and see if you need to deal with it before you bring your patient to transplant. Gotta make sure your patient has enough support for compliance and is willing to do that. And also, mixed chimerism is not a bad word in our sickle cell disease population as long as it's stable. And we've shown that as long as you have a myeloid chimerism of over 20 or 25%, you're in good shape and you'll keep your hemoglobin S down. If you look at the total medications that your patients take, it tells you the difference between Matsib and alternate. I'm not going to harp on this too much except to say that I show my patients these graphs and I tell them it takes you that long to recover and you've got to be patient and bear with me. If you are transplanted today, you are not going to be in great shape tomorrow. You're going to need to give it 2 years to be able to get over your hump and get better. The number of pain medications you take are going to come to zero if you have a massive donor transplant before 2 years. Not true with an unrelated donor transplant. It's going to take you longer, but it will. The green is good. So the higher the green, the better it is, but the longer it's going to take in alternate donor transplants. And the median hospital stay comes to zero very quickly. So again, green is good, comes to zero very quickly by 1 year in a massive donor, whereas unrelated donor, you're still up there at 1 year, you're coming down at 2 years. By 3 years, you don't need the hospitalizations anymore. So a big difference from what your patient had. So if you're thinking of support groups, and you're thinking of educating your patient before they come to a transplant, you got to be sure that they meet the right people and talk to them in terms of what they would expect for outcomes. Immune reconstitution is a very important part of what we track, and we track it for 2 to 3 years in our patients. It's a battle with insurance companies to get immune reconstitution done, but we have diligent staff that persist till we get them. Very important to know where they are in terms of their immune system. And then the gene-modified therapy that I referred to earlier now have different approaches, as you know. You can either change the globin by adding a beta globin that is tagged to the lentivirus that Bluebird is doing, or you can have the BCL11A gene either knocked out or the enhancer disrupted, where your hemoglobin F levels go up and stay very high to give your patient relief. And most of these are being done after myeloablative busulfan because nobody's had the guts to say we can do it with less and allow for long-term engraftment. There is one trial that is being run by Poonam Malik. She's doing a reduced intensity approach to increase the hemoglobin F levels, and time will tell us whether it's sufficient, because your ultimate goal is to reduce toxicity, and if you can back off, then that is going to be an advantage. Again, experimental is the word for all these approaches, something that we have to carefully step into. Bluebird's trial is probably the most out, or the furthest out in terms of data, and they've shown that you can get a 40% contribution with the new hemoglobin that is actually the beta globin that is inserted at about 6 months. The follow-up is really short, and we need to know what happens in 5 years, but unless we do these, we're not going to know, right? So it needs that follow-up. But that's a good start, and these other gene-modified programs are even more recent, so they're just starting out in terms of follow-up to see how we do with that. This is just a follow-up plan for each of our patients, and they include sickle cell disease specific outcomes, transplant specific outcomes, and then all the hematologic parameters that are necessary to follow. So there's a whole list of things that need to be diligently followed if you're going to say that you've made a difference in your patient long term. And if you look at the quality of life data, these are all massive donor transplants that got the TBI CAMPATH approach to their transplant. It's been shown that their quality of life is certainly in the short term much better once the transplant is done. Now, it's easy to say my patient's doing well, I think this is great. It's something else to say, I followed it rigorously and here is the quality of life difference. It's something that we need to do in our protocols. We looked at it in our unrelated donor transplant trial and showed that the change in health was actually significant at the end of 1 year, both for what the patient thought and both for what the parent thought, that it took a year before we got there, but their health certainly improved at the end of that year. If you look at their IQ, remember we talked about the drop in IQ with time. This is our unrelated donor cohort that had IQ testing done 2 years after they got the transplant, and it was done as a full-scale IQ, as a performance IQ, and as a verbal IQ. And in the majority, we had 2 patients where it dropped a little, but the majority of them either improved or stayed stable. A start to at least following this in the right direction. That's something that is very, very necessary for our patients, and something that insurance companies don't want you to do because of the cost, and something that has to be done either with extra funding or with a plan to make sure that you make a good effort to get this done with time. Now, it's getting easier to do this now with the NIH toolkit that you can use, and I would recommend, and this actually was we published this in Blood Advances recently and talked about what are the things, what are the endpoints that would benefit you to follow in the long term in your patients. And I would say that the domain-specific measures are, I think, there's a lot of expertise here in the room, but the domain-specific measures are important to track, and tells you what your transplant might have done or what your gene therapy might have done to your patients in the long term. This is just a follow-up of what your hematologic parameters need to be, and this is a lot more important for your gene-modified cellular therapy. Where does your hemoglobin need to be? How much needs to be supplemented by the gene-modified cells? Because you're not going to have 100% gene-modified cells in your patient, but what is it that puts you over the edge? Where does your hemoglobin stay? What is the level of gene-modified cells that need to persist long-term for improvement in your patient? So these are the parameters that need to be followed. And then last but not the least, the cost. Stacey Arnold from Emory has looked at this in detail and showed that with a massive donor transplant, you have a benefit to the number of visits, you have a benefit to the length of hospital stay, and you have a benefit to the cost, at least in the short term after you have your patient go through a massive donor transplant. And cost is not trivial because states are trying to figure out how to assess what the cost of maintaining your patients would be long term. And I think it's certainly something that she continues to look at, as do other groups, to make sure we know what the costs are. Because you know the transplant and the gene therapy is going to be super expensive when it comes into being for that one time for the patient. But if you can take the cost out to 10 years and you can show that there's a benefit, which I think hopefully we'll be able to do in an objective fashion, then you can justify not just your patient's well-being, not just your patient's health-related quality of life, but also the cost of that treatment. It's all, I think, necessary. So additional considerations that we need to track longer term, and I know I know that you've all thought about this, but long term, how much is reversible? What are the side effects of what you have given them? So clonal changes with time based on their exposure to conditioning, or based on anything that has been genetically modified that has been infused into your patients. And late toxicities, of course, of the agents that you've used to try to get them to where they are. Very important to follow, and this is where registries are going to be super useful, and this is where a lot of centers are now sort of working together to develop long-term registries that also have tissue repositories of cells from bone marrow or from peripheral blood to genetically test with time to make sure we don't have the clonal changes that we worry about. So in conclusion, I think there's a growing interest in the race for the cure. Past studies, I would say, are meant to build future studies on and target the right. I think is right. Your victories are slowly increasing. Your challenges, hopefully, are slowly decreasing. This is one of my patients who told me, she said, "Cure, you were the pot of gold at the end of my rainbow," is how she put it. And I thought that was so beautiful, the way she said that. But she certainly benefited from it. I do want to acknowledge a host of people that have worked to do this. I feel like I'm just the spokesperson for multiple centers, multiple transplanters, multiple sickle cell disease doctors, patients, families, and so on. But I think this is how we move forward. You work together, you get going, and you track very carefully what you've done to see if you've made a difference, where your problems are, and where you need to move on better. So having that, I think I'm good for time, 12:50, so I'll take any questions, and thank you very much again for having me. Appreciate it.